See, Johnny, could you give her invocation, please?
Dear Lord, thank you for this day. Please watch over us as we come together and do the work of the Cherokee Nation and its citizens' business as best we possibly can. Watch over us as we travel to and from today, and pay special attention to those who are serving in harm's way and our first responders that are working so hard for our best interests. We ask these things in Jesus' name. Amen.
Amen. Thank you. Shelley, roll call, please.
Yes, sir. Mike Dobbins.
Here.
Dora Petzkowski.
Here.
Keith Austin.
Here.
Danny Callison.
Here.
Julia Coates.
Here.
Sean Crittenden.
Here.
Joe Deere. Rex Jordan.
Here.
Johnny Kidwell.
Here.
Darrell Legg.
Here.
Wes Snowfire. Joshua Sam.
Here.
Mike Shambaugh. Melvina Shotpouch. E.O. Smith.
Here.
Condessa Teehee. Victoria Vesquez. We have a quorum.
Thank you, Shelley. Okay, first up on reports, Mr. George Vallier. George. There's George. Oh, I'm sorry. While you're being seated, George, we're going to entertain a motion to approve the minutes. In a second. All those in favor? Aye. Great, thank you. Now we're official. George.
Good afternoon.
Hello, George.
I think you've got my report there in front of you. A couple of highlights. Third-party collections are up this year. I've noticed since I've changed the format here, I don't have the exact dollar amount that we're up on this format, so I'll get that. We're doing much well. I think we are en route to collect. We'll be pushing 50 million this year, which is an all-time high for Claremore. That's what we're hoping for. The other thing is that we have scheduled, we've gone back to scheduling. We've scheduled our Kids Safety Fest the first weekend in June. That's Saturday, June 4th, from 9 to 12 there in the front lawn area of the hospital. We used to have that. Lots of vendors come in, law enforcement, the Masonic Lodge would come in and do the CHIPS program for small kids. It's a child identification program. Had a lot of very good response to that. We're getting that fired back up again this June 4th. And then we have started our survey readiness activities. We are within our 12 months before Joint Commission comes back to, is due to come back to Claremore. So those activities have fired up, and we started those. Also, our mammography unit received their American College of Radiography accreditation recently, so kudos to them. Any questions?
Questions for George? George, it's been a while back now, I lose track of time, but the Muskogee Nation pulled their shares from the Claremore. Can you kind of tell me what that means exactly?
They have taken any financial interest there at Claremore out. They've taken all their money out, and they use it for their patients, for their own clinics. Down in Creek Nation.
Okay, have you noticed less patients coming from the Muskogee Nation since they've done that, or just?
No, sir. They keep coming.
Well, that was my next question. Their new clinic is the cancer hospital in Tulsa.
Yes, sir.
And that's up and running now, is it not?
Yes, I think it is.
So I imagine you haven't discerned any difference in patient flow from Claremore as a result of that new clinic opening?
No, sir, we haven't. The folks that come to Claremore are coming over there for primary care, basic primary care, and we've not seen any difference.
Okay, can you tell, what about the shares the Cherokee Nation has there at your unit? What stake do we have there in terms of our shares versus what the Muskogee Nation currently has?
Well, Muskogee have zero now. They have no share in Claremore whatsoever. I'll have to check. Those numbers and percentages are all kept down in Oklahoma City. But I can find that out and bring it back to you next week, or have someone from area come with me and give you that information. Be glad to.
Okay, and finally, what other tribes have shares there at the Claremore unit?
The 7 tribes up at Miami that are part of that consortium, the Eastern Shawnees, the Wyandots, and the Katuas, still have some shares there at Claremore.
So UKB has shares there?
Yes.
Okay, all right. Okay, Johnny, did you have that?
Sir, good morning. Thank you for being here today. To back up what the chair was just talking about, when it comes to the shares, if the Creek Nation had bought their shares, pulled their shares out, but they still have citizens that are being seen by Claremore, and that's correct?
That's correct.
So that's extremely interesting that it would happen that way. So I also, can you confirm that whenever the Muskogee Nation pulled their shares out, did we purchase more shares at that point? Did we pay more into that system?
No.
We did not.
No.
So we have remained the same.
Correct.
Okay, my last question for you, sir. Whenever the Creek Nation pulled out of their shares, does that pull out of the entire IHS system, or does that pull out of Claremore Indian Hospital and surrounding areas only?
Just the Claremore Indian Hospital.
Okay, so they still are paid into the entire IHS system to where their at-large individuals can access the IHS system in other states where available.
That's correct. As long as they're a member of a federally recognized tribe, they're eligible to be seen.
Excellent. Okay, sir. Thank you, Chair.
And I might add, our citizens can be out of state and have access to IHS facilities too. Okay.
On the advisory council, which I sat on, I don't recall, does Creek have a voice in there now? Because it seems like they still have a slot in there, is that correct?
They still have a seat on that
And why would they?
because that advisory council is put together by you guys, the representatives that sat on there, and I sent down a list of everybody that still had shares, a financial interest in shares in Claremore, and I also shared that with Chief Wallace. And I think that is going to be a topic for discussion about who votes and who doesn't, and who should be allowed to vote at the next meeting in a couple weeks.
Yeah, it's on my schedule.
If you have some questions, you can call me and I'll visit with you about it.
Okay. Yeah, it just seems, if you don't have your stakes, then you shouldn't have a vote in there. I have numerous family members and community members who have accessed your ER in recent days, and I'll tell you, people, we're very fortunate to have that ER available for our population. They take care of people quick. They take care of people really, really well out of that facility, and their facilities have been upgraded to a point to where it's a great experience when you go in there. So your ER staff is absolutely doing a great job.
Thank you, sir. I'll pass that on.
I appreciate that.
Thank you. I'll pass that on.
George, thank you for being here this morning. So let's say for hypothetical situations, the Creek Nation gives $1 million for those shares. What are they getting for that amount of money that they buy those shares for if they still get to use the hospital after the money's been pulled away from you? Now, that may be a question that's.
Well, being a federal facility and a part of IHS, I'm required to see any member of a federally recognized tribe, regardless of whether or not they have shares or not. We see tribes from Southwest As you well know, there's a lot of activity up here in northeast Oklahoma in the summer with stomp dances and powwows and different functions. People come from all over the U.S. I have multiple tribes come in for care, primary care, ER care, that their tribes don't necessarily have money and shares in that hospital, but because they're a member of a federally recognized tribe, they're welcome to come there and be treated. So the same would be true for Creek Nation when they pull their shares out.
One other question. The IHS appeal system, what good does that do? Because most people, I mean, it's one doctor sending appeal to another doctor. So if you have a citizen out there, what are they, in the appeal process, what are they appealing? I mean, most people's had high school biology and that's it. So they don't even know anything about what's going on with them. So with that process going on, I know that's an IHS deal and you may not be able to help me, but what is the purpose of the appeal?
Well, sometimes a patient may have extra information. They may now have statements from their doc or medical records from that visit that they can include that the docs who review that case didn't have access to before. So that's when you submit that to that review committee to look at.
I see that, but still, I mean, most common folks that go to the doctor have no idea what's wrong with them or what's causing it.
Sure.
And why would the doctors not just communicate between themselves and make the appeal process to where that's my only question with it. And I'm not trying to be, mean or evil with it, but the point is that, most people don't have a clue. And if they call me to ask to help with this appeal, I don't know how to write the appeal because I'm not a doctor as well. So to me, it just seems like that with the age of the internet and everything going on, that those things could be shared back and forth without this process. But thank you, George. I appreciate it.
Yeah, it brings up some more questions, George. So if Creek Nation can pull out and they can still use it and still save their funding, what about Cherokee Nation? What benefit is it to pay IHS if we can still use it, especially since we have our own clinics and our own hospital? And we have so many issues with contract health. And I think everybody in here has had a constituent call and have trouble with contract health because the first sign is contract health, go to contract health. If you didn't call within 24 hours, then you missed it. If you didn't call within 72 hours, you missed it. And I could go on and on the list that they call and say. It just seems sort of ridiculous. Why can't we just take that money, go into our health system, use it, and just, because IHS isn't owned by Cherokee Nation. A lot of people think it is because it's in Claremore, but it's not. It's a federally program. It's part of that guardian over the ward type relationship. But I think we've passed that in Cherokee Nation. I mean, we do have the funding. I mean, we have our own hospital getting built. We're doing our own doctors. So, I mean, if we pull out our shares and our money in there, the patients are still going to get seen. But we still have our own clinics, and we could build our clinics to go forward. Am I correct on that, or am I wrong?
That's partially correct, yes.
80% partially,
Well,
40% partially.
You kind of mixed things there in your statement. You
Yeah.
talked about the primary care coming to see the doc, yes.
Mm-hmm.
Then you mixed in PRC and contract health.
Right.
Those are two completely different beasts.
Right.
Now, Creek Nation took all their shares out. They get zero contract health coming to Claremore. If a Creek Nation citizen is referred out by one of our docs, that referral goes to Creek Nation for approval or denial. We pay zero on that. And I'm familiar with what you talked about, just like what he brought up down there about the appeal process. You know, the Cherokee Nation pretty much eliminated the outpatient part of our contract health issues when they took all the outpatient money for Creek Nation citizens. We don't, all of our outpatient goes directly to the nation to be paid. The ones that you guys are discussing or bringing up are emergency rooms and inpatients.
Right.
So you could very well take all the contract health money.
Mhm.
That's perfectly within, your right to do that.
And they can pick and choose, like, take it out of Claremore, leave it at Sixth and Peoria, or the different ones, correct? Okay.
And you can pick and choose which clinic you want to take it out of, because the nation has they took over behavioral health at Claremore,
Mhm.
The public health nursing program at Claremore, and the WIC program at Claremore. So you can pick and choose, and and just like I said, take it a step further, the outpatient contract health service for Cherokee Nation. So you can pick and choose. You have the luxury as a tribe to pick and choose what you want to take over.
Okay, yeah, that's confirming, so sort of where I was going with that is Cherokee Nation, I mean, we have so many, I mean, we all get calls about contract health, that's just a pain. But, maybe we should just look at that to reprioritize where our money goes to Claremore as far as the contract health. I mean, we are getting bigger, I mean, we have our own hospital, and maybe we figure that ourselves. I mean, nothing against you, but
Well, I know.
it's a business decision, so. All right, thank you.
I'm
Thank
more
you,
than
Chair.
willing to sit down and visit with you guys, out of this arena, if you guys want to sit and talk about it, and I can get some folks down and we can get even more specific about dollar amounts and things like that.
Yeah, I think it's more, I don't really think it's the money, it's more the service. The problems with the service. I mean, because all of us get calls where there's some issue with contract health. Either the person they call is rude, or they've been denied an appeal and they don't know what they're supposed to do in the process. It's like you have to go through these hoops to get help. I mean, I know Counselor Callison, had a girl that, sat with a year for an elbow. I mean, that seems sort of ridiculous, but, that's where I'm going.
Sure.
It's sort of the service part of it, so. But, yeah, to answer my question, I appreciate it.
Okay.
Thank you, Chair.
This may be a question for Dr. Jones, or you may be able to answer it. Like we were talking about the denials, when they get the denial letter. Now, it's more like a pending, right? Like when my boy had appendicitis, there was an anesthesiologist come into the hospital. The surgeon might have been from a different, contract and this. The denial's more like it's pending until you get all your stuff together and we can take a complete look. Am I way off base there? Because I really don't like the word denial, and nobody likes the word denial. And I'm just wondering where that came from. Just to the average guy, they denied me. Well, no, not really. It's, in my estimate, if I'm not way off base, it's really give us a little bit more time and appeal it, and we'll look at it again. Am I on the right path there?
You are, and I agree with you that word denial and even our deferred letters are both so confusing, because the deferred letters come out and say your referral was deferred at this time, pending IHS getting more money at the end of the year. We don't ever get any more money at the end of the year. The denial letter, we changed one time, probably 5-6 years ago, and I was severely reprimanded for changing a agency letter. So that's why we've gone back to the standard letter issued from headquarters. Those two are written up there, and we are directed to hand out those specific letters. And I agree with you, because it says you're denied, you're deferred. Those are harsh words. And so, and I agree with you, but my hands are tied on those two. Yeah.
It is sure enough a federal thing.
It is. It is. Yes, sir. You bet.
George, if a person is deceased now, but the family called in for contract health within the time limit, but they died, like next few days, then they get a denial letter. Does his family, do they appeal, or who appeals at this point?
Yes, they can. They can, and we need to know that specific thing that they have passed.
Okay.
Yes, they appeal that.
Okay, but if nobody pay, well, who pays, I mean, where's the payment if they're deceased and they don't have,
So if somebody will let us know,
okay,
if somebody will let us know, if one of you two know that a patient came in and then passed, shortly after that ER visit or that hospital stay, let us know that.
okay, all right. I'll let them know.
Oh,
Thank you.
please do, yes.
All right, thank you.
George, first, thank you for the change of format. This is great. It's so much more information than we used to get, and it really allows you to kind of dig in a little. After today's length of your talk, you may say, gee, dang, shouldn't have supplied him with that much information, huh?
No, that's what I'm here for.
But no, it's a great new information. Thank you. I do notice in the positivity rate for the month that's reported here, it's of 1,023 COVID tests. There was 605 of those were for Cherokees, which would mean 60%, right at 60%. So that's about what your hospital sees, is about 60% of Cherokee population in a lot of things. But what would you say is the typical percent of your hospital population that is Cherokee Nation citizens?
That's probably a pretty good ballpark estimate.
From a lot of reports I've seen, I think that runs pretty close. That's why we need to be involved with that hospital. They're seeing 60% of their patients are Cherokee Nation citizens. It sits within the Cherokee Nation in one of the most populated communities within the Cherokee Nation, but yet it's a community that has the least access from the Cherokee Nation health system. So it's important that we are partnering with them and not becoming combative with them. Thank you, George.
Yes, sir.
Mr. Miller, one last thing, sir. I know it might feel like you're on the hot seat up there, but listen, we truly appreciate everything that you guys do over there. I mean, obviously, if you're seeing, you're seeing, hundreds of Cherokee citizens a month, and that goes excellent, and we appreciate that, and we applaud those efforts. So don't take any of the questioning as a derogatory on any of the work that you're doing. I'm sure that's great. I have one question for you, though. Whenever you talk about denied and deferred, what I would like to see, if possible, in your report or in the future is how many of those are appealed, and of those appeals, how many of those appeals are then denied. Okay. That would be interesting information to see in your report overall. But other than that, we've brought up some good points today, and it's been a great discussion. And I just want you to know that that this isn't a politics of piling on here. We understand that you do great work over there, and Claremore in general does great work to those people. We're talking about a few cases that are just kind of outliers, and they bring up good points, and I'm sure that we'll discuss those more in the future. But thank you for coming, sir. Mr. Chair.
Oh, thank you, and we're always trying to make it better. That's why I'm here.
George, on the contract health, at what portion of the Cherokee Nation, if you go to the AMO clinic, what portion of the Cherokee Nation gets referred to IHS for these appeals to be written? Would you say half of the Cherokee Nation goes north to yours? I know I live in District 15, and I know probably just south of Locust Grove, anybody and that has nothing to do with which clinic you go to, from my understanding, it's where your address is.
Yes.
And from your address, so you get all of Speaker Shambaugh's district, all of Councilor Vasquez's district, all of Councilor Petkowski's district, all of Councilor Austin's district, and all of Councilor Deere's district. Is that true, sir?
It's probably pretty close, because I'm not familiar with
Right.
who's in what district. But yes, we have a large contract health delivery area.
So what you would say was, if they were seen at AMO and the referral went through to you, you're the ones that's going to deny it. And when we say denied, do you look at it again after it's denied?
Not necessarily. If they go to one of the clinics and it's written to us and it's for an outpatient procedure, it goes back to Cherokee Nation for
Okay.
approval or denial. The only ones we get, the only thing that comes to us from any of the counties anymore are emergency room visits or inpatient stays.
Ambulance rides as well?
Yes,
Oh,
yes, all the outpatient has been taken over by the nation.
Okay, and I clarify, when it's denied, you're not looking at it again unless these people appeal, is that
Unless they
correct?
appeal it.
Yes, sir, thank you.
And I assume, George, I know it's well known that Cherokee Nation, our contract health services, we are the payer of last resort. So I assume that's true with Claremore,
That's correct.
that you're the payer of last resort. You look at all possible facets of possible funding before Claremore IHS is even considered.
Yes, sir.
Is that correct? So that takes time to look under every rock for resources in order to help meet the needs of our citizens. And I get calls from across the reservation, and there's a map that's probably all of you know what it looks like, but it outlines or shows if we have a constituent that needs contract care for outpatient, it depends on where you live, or if they need contract health for inpatient, it depends on where you live. And there's a map, there was one in our break room back there. That'd be real helpful if there's any question, because that's first thing I ask when someone calls, where do you live? And was it
Yes, sir.
outpatient or inpatient? And then that enables me to at least go forward with whatever their
Yes, sir.
needs are at that point. Great. Any other questions for George? You better head out, George. Thank you, George.
Thank you, guys.
Paging Dr. Jones.
Good afternoon.
Hello, Dr. Jones.
Nice to see everybody without mask on again, isn't it?
Amen.
We are in the green once again on our counties, all of our clinics, so we're very happy to have our mask as optional right now. So just increased our morale around the clinics, I think, so it's been a good thing. If you don't mind, I'll get right into the report. Typically, some of the things we look at, you've already probably looked at, but I know you guys spend a lot of time talking about contract health. If you look over on that, 96% approval rate on this last month. So, anywhere between 2 and 5% usually come up for reviews, but 96% of them are automatically approved and moved forward. So the ones you do hear about are the very small numbers that come up for review, and typically we have people in our system that work with those that are initially denied to help them. Right, I know there was a lot of questions about the appeals process, but we do have folks in our contract health system that do help people when they have trouble getting that information together. So, so just FYI on that. Our ambulatory visits continue to rise, as you can see in our report, and along with that, our revenue continues to rise. So that's a good thing. We're generating more revenue, and we're trying to help support those services and expand them, the ones we can, with that third-party revenue. So we've been fortunate to see that continue to rise. Vaccine numbers, we're over 104,000 on vaccines administered. There is a new, recommendation for those over 50 to get their third booster. So that is available to those folks at all of our clinics. Since the numbers have dropped significantly of people walking in, we've pulled that back to our primary care and pharmacy areas. So if you do have a constituent that's wanting a vaccine, to go ahead and get boosted, if they would call, they will set up a time for them to come in and make it more efficient, so they're not coming in just sitting and waiting. Because we don't have our specific clinics just for vaccine running right now. There just wasn't a need. The numbers had dropped off so much, we had a lot of people that were just sitting and waiting for someone to walk in the door. So, but it is still available at every clinic. Construction, we're coming to a completion finally at Stillwell. I know Counselor Crittenden and Counselor Sam you guys are probably pretty happy about that. We finally have our grand opening on April 21st. We also have, in the final stages of the hospital planning, we just finished our last phase of schematics with all of our staff, and so we're looking forward to the final drawings that should be coming out soon on the hospital. And we're in phase 2, I believe, at Salina, so we're just getting ready to start the second phase of those drawings. So what that means is we meet with the staff, we kind of get everybody's general ideas, we come back with an idea of how it should be laid out. They meet again, go over them, and each time they get more specific into, even as where outlets go, where doors open, if it gets into the patient flow, where elevators, if there's elevators involved, how are patients going to flow in and out of those. It's very, very specific, and it takes a lot of time to go through those drawings. So each department focuses on their area, and so anyway, we're in that third phase, or just finished that third phase with the hospital and entering that second phase with Salina. This last week, we had our annual survey with DNV, which is our accreditation for our health system. They were here Tuesday through Thursday doing survey and looking at all of our clinics and all of our in our hospital, meeting with our staff. They did it virtual this year, so we actually carried an iPad around, and they would tell us where they wanted to go, and we would go and show them what they wanted to see. And then they did virtual interviews, and we got our exit interview on Friday. They were very complimentary of our system, and they're going to be giving us a full report in the next week on anything that they see that we need to improve on or any more further clarification. So that went real well, and we were very pleased about that. That's about all I have to report to you this time. I know there will probably be questions around the legislation that's going through, and I'll be glad to answer those at that time when it's appropriate.
Darrell? Hey, Dr. Jones. First off, I was glad to share that text that I got from a constituent on his experience at the clinic, actually at Hastings. A lot of times we don't hear that, but in the new hospital, is there any way that we can put in there for a physical rehab center for those that are getting out of surgery? Because just here recently, I've gotten 2 cases where people's insurance would run out, and they would still have like $54,000 bill just from having to be there for 2 weeks longer. And I think that's maybe one area where we're slacking, or we just don't have it yet, is where these people are able to get out of a back surgery, but they need the physical rehab, they can't go home yet. Can we put that in the plan for our new hospital?
We can definitely look at it when we've talked about things of that nature. We are incorporating occupational therapy, physical therapy, and speech therapy into to our inpatient systems now. So
thank you, sir.
That is being incorporated into it.
Okay.
Dr. Jones, we don't recognize UKB ID cards, like when they come to get medicine, if it's a controlled substance. They don't accept UKB.
Any federally recognized tribe is eligible for services. So are you talking about for identification purposes?
Yeah, identification.
I don't know the answer to that. If it's not, identification purposes, are required, there's certain requirements federally with that, and I don't know if their identification cards
I
are
know
recognized federally or not.
This person was going to get some Tramadol, and only ID he had was a UKB card, and they wouldn't let him have it. But if somebody, came and picked it up for him, they could have it. So I don't know if I did right or not, but
Yeah.
he was walking, and I know where he lives. He lives about 3 miles from there. So I was just going to give him a ride to his house, and he said, "Can you help me get my medicine?" I said, "What's the deal?" He said, "Well, I need someone that has ID to pick it up for me." And so I went ahead and did it, but
Yeah, so those regulations, when it comes to controlled substance, are set out by the DEA, and they have certain parameters, and those identifications have to be something that's recognized by those federal organizations before we can accept them. So yes, it is a kind of a weird thing that someone else can pick it up, but what you're doing is you're signing that who you are, and you're identifying who you are, and you're signing that you're picking that medication up. So, and it has to be tracked that way. So,
okay.
yeah.
So it's not a crime or nothing to do that.
Oh,
I've already did it.
I'll let the AG talk about, let's try to stay out of the criminal side of it.
Yeah, that's why the AG's here. I was wondering why.
Dr. Jones, if we're IHS, so we see every tribe that comes through. Doesn't matter what tribe you are, you can go to one of our 10 clinics or Hastings. What do we do as Cherokee Nation if, like a Katua has to be contracted out? Do we do that? Do we send it to the IHS facility? How does that process take place?
So we aren't IHS, we're Cherokee Nation, so there's a differentiation there. When it comes to contract health funds, we do get contract health funds from Indian Health Service. Those are geographically bound, and that's what you were talking about earlier, depending on where you live will determine what pot of money that comes out of. And that's open to any federally recognized tribe. Now, there are some things that we do that are specific to Cherokee Nation, and the hearing aid legislation that you just passed is an example of that. That comes out of Cherokee Nation funds, and it still enters into the contract health pot, but it's different money, it's tribal money. So we have to keep that separate. And that's only a Cherokee program versus an Indian Health Service program, which is all services that are available through that scope of care.
So if there's a Cherokee that lives outside the reservation and he comes to the clinic and he has to have outside help, we take care of it. We don't just say, just because you don't live on the reservation, we don't mess with you.
Not necessarily. It depends on what that service is and what, the emergent needs of that service and things of that nature. So, because it is bound by geographic location. So if someone outside in another geographic location comes into one of our clinics, then that's going to go back to that geographic location of IHS money to be pulled out of. That's why you have that process that you guys talk about and you get hung up in with people who live in the Claremore service unit. They have to go through that process, be denied, and then we try to pick it up where we can.
Thank you.
Yeah.
I just had a question, since we're talking about IHS and Creek Nation and Cherokee Nation Health. Is there a rule that if IHS is in a certain area, that there's a mile radius that you can have a clinic of a tribe, or you cannot?
Not that I'm aware of. I don't know that rule. I have to research that further.
So I was wondering if that rule came into effect, if Creek Nation pulled out of that IHS because of that. That way they didn't have any skin in the game in it. That's why they could do the cancer treatment center and be able to do that as a clinic.
So the part about the shares and stuff that I think is a little bit misunderstood here is when you pull your shares, you're not buying shares.
Right.
When you pull your shares, the money that was going to Claremore service unit is now going directly to the Creek Nation.
Mm-hmm.
Okay, so the money that was going there is not going there anymore. It's going to Creek Nation. So therefore, they don't handle any of that contract health service money because it's going back to the Creek Nation. But they still will, in my understanding, I'm kind of talking outside of what I'm responsible for, but they still are responsible for seeing anybody that's a member of a federally recognized tribe.
Mm-hmm.
So that you're not buying shares into a health system. You're actually, when you pull your shares, you're taking money from that health system.
Right. I was just, the reason asking is the radius in District 13 is, we do now have a third-party clinic. Why has there never been a clinic in that area? I know we got Oshaleta and the other ones, but I didn't know if that had a factor on it with it being in Claremore, being that close, is why there was never a clinic there.
So are you talking about the third-party clinic up in Catoosa?
Yeah,
Or the
but
employees?
say it wasn't there, why there was never a regular Cherokee Nation clinic there?
Part of that is the way that we're structured, we can't go out and offer services to non-beneficiaries.
Okay.
Okay, and so the way that clinic is structured, they can, because a lot of employees, it's an employee clinic and it's offering services to employees even though they may not be beneficiaries. Does that make sense? So that's how that has come to pass, and that's why it's ran by a third party rather than us, because we can't go out and offer services to non-beneficiaries except in very specific, narrow circumstances like life or death situations. Or we do have a partnership with Northeastern Health Systems here in town. If they go on divert in their ER for some reason, we pick up those patients until they come off a divert, and then we'll typically transfer those patients back.
Okay, well, say that third-party clinic wasn't there. Owasso being the largest city in Cherokee Nation, still no clinic. But we have the ones in Oshaleta out in the country. Still doesn't define why there's never been one rose and put in Owasso.
Yeah, I don't know the answer to that. That would be a question outside of my purview. I can't tell you that why there's strategically there wasn't
Yeah.
one there. You know, the strategy for where the clinics were put in place many years ago was to try to have a clinic within 30 minutes of every Cherokee population or community. And so that's why they were, and I'm sure Claremore was part of that strategic plan at the time because it does have access to health care.
Okay, I just didn't want to verify if you knew or you did not know, if that was the reasoning behind it, why there wasn't a clinic there, so.
Yeah, I don't know the answer to
All
that.
right, that's it, thank you.
Yes, thank you. Dr. Jones, this might be a question for Dr. Gann, but it's about Omicron variant and the boosters. Would you rather me ask him or?
He could probably answer that a little better than I can, but you can go ahead and ask so he can get
All right.
prepared.
Well, first I wanted to establish, what is the dominant strain right now, variant? Is it still Omicron?
Omicron BA2, I believe, but I'll let him answer that for
Okay.
sure.
Well, I've got a couple, we'll just wait on him. Thank you.
Doc, real quick on the, I want to make sure I got this right. I just told somebody this a couple of days ago. At large, come in, use the facilities, anything in-house. But as far as sending them out somewhere, there's no gray area, right?
Yeah. Anything in-house they're eligible for.
But no sending them out.
Right.
Okay, thank you.
Yeah.
Black and white answers. I mean,
Yeah.
we all wish they would, you know, we all wish it's more, but the black and white answers are pretty easy to tell somebody. Thank you, Chair.
So I'm sure Wilma P. gets a lot of Northwest Arkansas citizens, so when they come and use Wilma P. and they need contract care,
Yeah,
It's not
it's not available. Now, there are in certain situations, the ability to do what we call a non-payment contract. And what that does is if we have and we did this for years with the hearing aid program, we had a contracted amount set aside with hearing aid companies. So even though they weren't eligible for a second hearing aid through us, they got to pay our rate, which was considerably reduced. So there was a benefit to coming to us and getting that non-payment contract, because it was about, 15% of what the retail cost was on a hearing aid. So it was significant savings.
Dr. Jones. I see none. Thank you, Dr. Jones.
Thank you.
Ready for public health, Ms. Lisa Pivek and Dr. Gann. I think they're both here. Yes, they are.
Good afternoon. How is everyone today?
afternoon.
It's really nice to see you. You do have the public health report in front of you. There are a few things I'd like to highlight on the public health report this month. Last month, when I was not here, I understood there were a couple of questions about our tribal health assessment that is in progress. It is actually in the graphic approval stage at this point. The tribal health assessment is probably the most complex document that we put together as a public health department, and it contains lots of information that we want to make sure we include everything we can from every source. So it's looked over and over several times, so it is in that graphic process. Hopefully by next month we will have that ready for to be able to be distributed. One of the projects I wanted to mention today that's been in your report, but I haven't had a chance to really talk to you about it, is the cross collaborative that we are working on in public health with several other departments and divisions across Cherokee Nation. It's called Working Together. And we're at a stage now where we're meeting every 2 weeks. We have representation from education, language, commerce, environmental health, environmental services, some from administration, and a few other places. And we are working on a collective project to see how we can better work in concert to serve our citizens in our areas. What can we do to break down those silos between departments and divisions and get information to one another quicker and actually work on goals together for each community? So I wanted to let you know about that. One of the things that we're doing right now is working on what are Cherokee indicators of wellness. You see indicators of wellness across the nation, a lot of times are related to chronic disease or health outcomes. And what we are asking as a group is, what are the wellness indicators? What does it mean to be well in our Cherokee communities? And that is something that we're drafting and will obviously be sent around for input and approval and thought process. But I think it's something that no tribe has done. I think maybe one across the United States, but it's something that we find very important, and it's a good tool to be able to bring every division in the Cherokee Nation together behind those indicators of wellness. The CDC report, the CDC biannual Tribal Advisory Committee meeting will be hosted by the Cherokee Nation in August. It's August 3rd and 4th here in Tahlequah. This is a huge undertaking and a great honor for us to do that. There'll be many leaders from CDC centers, institutes, and offices here during that time, as well as representatives from tribes all across the United States. So we are looking forward to that, and as we progress through that, we'll give you more details. CDC on its side does most of the logistics. They come for a visit here and look through everything, look at the facilities, and make some of those arrangements, but we'll keep you updated on the agenda and anything so that you may be able to attend if you can. Another thing that was asked about last month, and I'm happy to report to you that the community health assessments are completed. They're in the process of being distributed right now. But the most important thing I want to talk to you about is those county health assessments are written pieces of paper that you can look at to look at information for your county. But we have a tentative launch date on May 1st to launch our new public health website. And on that public health website will be a searchable database so that communities, counties, yourself, you can get on and pull data from your area. So that if you have a specific grant that someone's working on, a community grant, if you want to know something about a particular area, you'll be able to look at that. It will contain publicly available data. The company that we work with has some proprietary, and then as we put more of our Cherokee Nation gathered aggregate data on there throughout this process, you'll see it start to grow. And that's also part of the new website that we've updated with more information about public health. The summer EBTC program, the Electronic Benefits Transfer for Children, is up to around 11,000 applicants right now. That application closes this Friday. So if any of your constituents have children and are interested in applying, please do so. We'll make sure that we get you more information on that as it moves through. And for Wings, I think all of you know that we're happy to say that we're back in person with Wings. The first race was at the end of March. We still offer the virtual option. We had about 503 participants at this race, but only 150 in person. So we had, the rest of those participants were virtual participants. So we are going to remain to keep both options available because it seems to be popular for some folks in communities who maybe can't make it on a Saturday or they're working with their walking groups. And in that, we're also scheduling our walking groups to kick off to support the Wings programs. We're back in the communities doing that. And as you look through the report, you can see that our staff are back out trying to initiate our community face-to-face programs the best that we can. We appreciate your patience with us through COVID and diverting our resources to other places. We're excited about catching up on the things that we've missed the last couple of years and providing you with more rich public health information as we come for you each month. And I'll let Dr. Gann talk a little bit about COVID at this point.
Good afternoon. COVID's still here, but we're dealing with it. In the United States, cases have plateaued over the last month or so, averaging 26,000 cases per day. In the U.S. as a whole, the number of deaths continues to fall well below 500 deaths per day in the U.S. There are a few states where numbers are picking up. New York is leading the way. It's still at a low level, but it's trending up. So we're watching New York very closely to kind of predict what's going to flow through the country over the next several months. Florida is starting to pick up, Connecticut, New Jersey, and a few other states in there. California is still low and flat, as well as Texas, so two other really large states. In Oklahoma, we're at about 120 cases per day as a state, and that is dropping still, about 5% over the last 2 weeks. So it's still looking good. Cherokee Nation, we're averaging between 1 and 2 cases per day. And when numbers are that low, one family gets sick and the number jumps all of a sudden. But the amount of virus in our community is very, very low. That's really good to see. We haven't had a patient admitted to the hospital to Hastings with COVID for well over a week now. So it's really encouraging. As we look at the numbers and what's going on with the different variants, I think we will have another surge in northeast Oklahoma. It's still a ways away, at least a month, maybe 6 weeks. But can't figure out how bad it's going to be, if the numbers will be really high, if the hospitalizations will be high. We just can't tell yet. But know that every day the epi team at Public Health is tracking things, and we're keeping an eye on it. There's a question about the BA2 subvariant of Omicron. In the United States, the estimate now is about 72% of all the cases are the BA2 subvariant, which many believe is what is causing the uptick in cases. In Oklahoma, the new data that came out this morning showed 21% of the cases in March were the BA2 subvariant. So but that was only, I think, 86 cases, and we don't have any data for April. So we expect that percentage to go up. Of course, those over 50, we encourage a second booster shot. The two good research studies, one out of Israel, talking about the effectiveness of a second booster, right? So why bother? The data, which they're still adding to it, is that 4 weeks, the vaccine effectiveness from getting COVID is about 30%. So that doesn't sound so great. But the protection from hospitalization and death and severe disease is still in the 90% range. So encourage those who qualify to get the second booster. And of course, if you haven't received any vaccinations at all, now's the time before we get the next run. The CDC community risk levels I talked about last month, those have been coming out more regular. There's a little bit of issue with case count. So the community risk levels have 2 tiers. One is for a county who has a low number of cases, and the second tier is for those who have a high number of cases. Then your risk level is based on the number of hospitalizations that you've had and the percent of beds that are occupied with COVID. So if you have a lot of cases, you're automatically going to be in the yellow. You can't be in the green. What happened last week is some health systems in Adair County didn't get all their cases turned in from the last surge that happened in January, so they turned all those in. And so the state health department can look and see when those tests were done, and they don't count them for last week because they know the tests were done 6 to 8 weeks ago. But CDC can't see that for some reason. So if you look at the map, Adair County is in the red for case count. It says there are 88 cases in Adair County, but there are only 2 that actually were tested during that week. So what's likely to happen is at the end of this week, Adair County will be in the yellow for risk level, and that's not really true. So I'm going to try to get in touch with CDC, see if there's some way they can adjust the data to account for that. But the state helped us figure all that out, and we'll be communicating that as best as we can. That's all I had on COVID. Are there any questions for me on that? Yes, ma'am.
What time period in between from one booster to another? Is there a waiting time to take?
Yes, ma'am. So between the primary series and your first booster, it's 5 months. And for the second booster, it's 4 months.
4 months.
Yes, ma'am.
Thank you.
You're welcome.
This has to do with the public health. The lunches Is that under the public health for the kids in the summertime when they leave school?
Yes, so the USDA operates, it's a federal program that has WIC. So WIC is not part of IHS, it's not a piece that we pull out, it's an actual program funded by the USDA. The USDA has offered this summer electronic benefit transfer for children for the last several years as a pilot project, and they're looking to make it permanent after this series of pilot projects. But it is for individual students that qualify for free and reduced lunch to get the actual card that's $30 a month per child in the household for May, June, and July.
So they're giving them $30 for food for the whole month?
That's the USDA guidance, that's what they offer for us to do, is give $30 per child per month.
And do they have did you say the application was coming to close, or?
The application has been online since the first part of March, and it closes this Friday.
Okay, so do we have any way, being in education for 41 years, I can tell you you're always a day late and a dollar short. So when we look at this, let's say we get kids at home in the summertime and they don't have anything to eat. Is there any way that we can help those kids out for that time period through the nation, or with that end closing, they're just out of luck?
With this program, we're restricted to the $30 per child per month. Now, what happens a lot of times is that schools elect to provide summer feeding programs, and they offer transportation, and they take kids to school, and we see that happening a lot throughout our area. We don't have a list yet of who those summer programs are going to be, so that we can refer people to those so that their child, and in a lot of places, as you noticed during COVID, they prepared lunches for people to pick up for their children as well.
So how did we actually broadcast this? Was this done across the internet, or was this email sent out to these folks, or did the schools do it, or how did they come about knowing this?
So we did have a launch on the website. There was a news story about it as well. Plus, we work individually with each school, and each school gets to decide whether they want to participate in this or not, because they have to get the parents' permission to let us make sure that that child is eligible by USDA rules. So we did advertise it pretty widely, hoping that more people will see it that need it. And the schools had information to give out to children as well. Yes. And I did want to mention that earlier, that USDA does not have a tribal set aside for WIC, but we apply and we get funded through WIC. So it's a little bit different. It's not an actual program that has anything to do with the Indian Health Service. So.
A few years ago, your team, as well as the folks at Will Rogers Apartments in Claremore, put some exercise equipment in there. And it's been pulled because of the community activities and community space during the COVID shutdown. It is time for it to go back, I might add. But honestly, we need better equipment than what was delivered. It was secondhand equipment. It was very, very worn equipment. And we need to assess each of those communal living environments that we have like that, where we have appropriate space, and do that. It encourages healthy activity, and I really hope you'll help us find a way to make sure that each of our communal living environments have appropriate exercise equipment in them.
Yeah, that's part of the work that we are currently doing, is looking at each environment, how to increase wellness access and access to activities. But that's going to take some time. And in the individual reports that you get, you'll see the inventory of what was available at the time of the report when we put it together. Now, those are ever changing, and as you mentioned, some things probably changed due to COVID, and we're going to have to continually reassess that and make sure that we make recommendations on what should be happening in each area. But thank you for that. Appreciate it.
Any other, Junior? Go ahead, Junior.
On those WIC cards, I know they mailed out a deal and said you could get them too, on the deal. But, in the summertime, a lot of the kids are down our way, that they take them to their grandparents for the summer. and they don't have the card, is there going to be an emergency where they can file to get a card if they missed the cutoff?
You know, I'll have to talk with WIC, and they'll have to reach out to USDA. The problem is really getting it on USDA's guidelines, getting it out into the community, because it has to be out on certain dates. It has to be completed by a certain time, and having the cards put together and getting the money put on them and mailed out is a little bit of a process, but I will definitely check into that. Now, their parents can still enroll them up and through Friday, so I really, if anybody that's watching, please, if you're interested, go on and fill out that enrollment form, please.
But a lot of time, if you're going to send your kids to your
Yes.
grandparents you don't care if you're enrolled or not. They're not mentally good enough shape to do that. But then the grandparents get them, and they would do it, but they can't. So if you could check in there.
I sure will, absolutely. And I understand that. I spent most of my summers with my grandma. So.
Hey, Ms. Pivick. I know I mentioned a few months back about possibly getting a farmer's market program going with WIC. I didn't know if you had a chance to look into it. Have you been able to find some stuff on it?
Yeah, that application is actually due at the end of August, and
Okay.
we're planning on trying to put together a proposal for that.
Okay, perfect. Yeah, I was just looking that up here, and I thought I remember you saying something. Also, they do have a benefit delivery modernization grant
Yes.
out there. Do you see? I'm sure you probably caught that one too. Hopefully we get both those. So awesome. Appreciate you looking into that. It's going to be exciting if we can get those going. I think it's just seen like 4 other tribes are doing this.
Right.
That would be a big thing for us and getting local farmers involved in the whole aspect of it. So I appreciate you looking into that.
Thank
All right.
you.
Appreciate it, Chair.
Lisa, the WIC cards now, they're income-based, right?
They are distributed to, the child has to qualify for school, for free and reduced school lunch, free or reduced school lunch. And we get that information from the
And of
school.
course, in no way it's going to affect the family's eligibility for food stamps, commodities. It's just a supplement.
It's a supplement. A lot of times, no, it should not impact the family's
Awesome.
income.
Thank you.
No.
Yes, these are for Dr. Gann. Still have a couple of follow-up questions.
Yes, ma'am.
Yeah, thank you. Most of the things that I had questions on were already covered in your discussion and some of the other people's questions, but regarding the booster shots, and you said people over 50 are encouraged to get the third booster, are they receiving the same solution that came from their original shots?
I don't know the dose of the booster. The CDC recommends that with all your COVID vaccinations that you stay with the same manufacturer, although it is allowed to go between the two, but I don't know the dose.
So how do they know, like, so we're on a BA2, a subvariant of Omicron that came out last year, right?
Yes, ma'am.
How do they know that the medication that they're putting in the third booster is helpful at all? And what are the symptoms of this latest strain?
So the way we know how helpful it is, another booster is the research that I mentioned earlier, where BA2 has already occurred in the studies coming out of Israel and a few other countries. So they are working on a more specific vaccine in the United States and other countries, but it's still early and nothing on the horizon immediately to have a vaccine that's specific for BA2 or any other variant. And what was the other part of your question? I'm sorry. Oh, the symptoms. So the difference, the symptoms between the original Omicron, the BA1 and the BA2 are the same. We think BA2 is anywhere from 30 to 80% more contagious, but it's less pneumonia and more the upper part of your respiratory system that's infected. So.
Okay, one last question, and you may or may not know this, but when you were talking about where the cases are on the rise in certain states, and you mentioned, I believe Texas was the last one that would be closest to us, and you're expecting Oklahoma will probably get another wave. How do you know where that's coming from, or do you know where it's coming from? Which part of the U.S.? which side, which
Well,
coast? or-
based on our experience with the other surges, daily, we look at the numbers and where they're coming from each state, and you can just see the flow. So it's New York and Connecticut, the numbers are going up in Florida. And with the last surge, it came down from Missouri, and it hit in northwest Arkansas, and it hit northeast Oklahoma, and it spread from there. So as far as how it got into the United States, I mean, there's international travel now. Canada is experiencing the beginning of the surge, and Mexico is just getting started. So it's out there, and people move around, and they spread the virus. Simple as that.
Thank you.
Yes, ma'am.
I've read a little bit about, the mask mandates easing up and, of course, trying to get back to normal. And I've also read there's places that are having more flu cases now because, we don't have to wear the masks anymore. Are we experiencing an uptick in flu cases here? Some places are.
We are, but it's not too significant. Usually in the flu season this time of year, the cases have close to finished, like we would have peaked in January and the beginning of February. So we're still at a level higher than usual, but it's nothing compared to a usual flu season. Yes,
And-
there's plenty of flu out there.
Yeah. And we really didn't have it, did we? I mean, when COVID was really going strong, we didn't really have the flu a whole lot, I heard.
It's amazing. You look at last flu season's number of hospitalizations and cases, and it's flat. It was really, really something.
Probably mask and washing hands and all that stuff?
Plus some yes, yeah, absolutely. Masks and washing
distancing.
hands and distancing, that
Yes.
prevents the spread of everything. And there's also a little competition between COVID and the flu as well.
Okay. All right, thanks, sir.
Yes, sir.
Any other questions for Dr. Ganner or Lisa? Thank you. Public health information, informative as always. Thank you very much. Okay. That's all our reports, old business, none pending, new business. We have one item. We have a number of sponsors. If I could, let's see, Dora, would you mind reading that, please?
Public Health and Wellness Fund Improvement Act, and I put that in the form of a motion.
Okay, we have a motion and a second. Discussion.
Mr. Chair.
Julia?
Yeah, I'd just like to be added as a sponsor, please.
Okay.
Thank you.
Counselor No Fire want to be added too, Shelley? Any other discussion? If not, all those in favor, say aye.
Aye.
Opposed? Motion passes. Oh, I'm sorry, yes, we'd like to have this go to full council, yes, later on today. Thank you, Shelley. Okay, any announcements? The only one that I see on here is the next meeting is scheduled for Monday, May 16th. I might add that our Docks Rock banquet, annual banquet that's been on mothballs the last 2 years is scheduled for May 7th at the Hard Rock. So if your counselors can make that, I know that our physicians really appreciate that event. That's on May the 7th. I believe it's 6 o'clock. Okay, I need one more motion. Sean, you want to move to adjourn?
Second.
Okay.